We present our technique for doing a safe and bloodless laparoscopic myomectomy in case of 8 cm corneal myoma. The first step of the procedure is to open the peritoneum from the right round ligament to the right IP ligament to develop the retroperitoneal space, and if need, to increase the dissection, and our goal is to reach the ureter, which is our first landmarks. You can see the ureter, and we have just to open a space lateral to the ureter, and we can easily discover our internal iliac artery, which is our goal for the vascular control. At this level, during this dissection, take care not to injure the internal iliac vein, which is closer than we think. You can see the good placement of our bulldog clamp on the internal iliac artery on the right. Let's repeat the same maneuver on the left side. We open the peritoneum lateral to the IP ligament. We follow the bubble and we remove the connective tissue above the ureter. You can see the ureter is clearly seen, and as I said before, we open the lateral space to the ureter and we will reach easily our internal iliac artery, which is plastered in this case on the external iliac vein. During this dissection, take care not to injure as well the external iliac vein. You can see we skeletonize the internal iliac artery and we medialize the ureter. That allows us to put safely the bulldog on the internal iliac artery, and it's mandatory to control the bulldog placement, and because it's important not to put the bulldog on the ureter. Let's do now a longitudinal hysterotomy just above the corneal myoma, and quickly we identify the myoma and we will track the myoma outside its bed with a 10 mm Pozzi forceps, and as you see we will try to use as less as possible the bipolar energy, and if you use the energy, apply the energy on the myoma and not on the healthy myometrium. You can see the extraction is quite simple and we don't lose time for electrical hemostasis. We use a Vicryl 1 40 mm needle and we will do our classical uterine closure by interrupted suture, double flat knot, and we invaginate the tissue inside the myoma bed, and you will see with this first knot you control more than 50% of the hemostasis. We continue. As you see, it's not a problem if you put inside your stitch the utero-ovarian ligament, and for this technique it's mandatory to go as lateral as possible to have a perfect wound closure. Double flat knot, you can see we lock the knot, the assistant block the knot, and the second loop will be done on the same side, that same way that the first knot was done. We continue upward. You can see we pass our knot 2 cm outside the myoma scar. The assistant invaginate the healthy myometrium, and we go outside on the left 2 cm outside our myoma scar. You can see the assistant invaginate the tissue, and with this technique we remove all the dead spaces that are the reason for all the post-operative complications. You can see this is our last knot. Take care at this level not to put inside your stitch the proximal part of the tube, and Next, same technique, and it's important to squeeze the knot till there is a blanching, and to do the second knot in the same way that the first knot was done. So you can see the myomectomy with this technique is quite simple, quite fast, quite bloodless with the vascular control. And it's time, after controlling if there is no occult bleeder, to do the morcellation. We use for that a 15 millimeter morcellator in the left iliac fossa. We remove now the bulldog clamps, and we control if there is no occult bleeder around the internal iliac artery. You can see. And we remove in the same way the left bulldog clamp. We control the hemostasis, we clean the pelvis, and we remove all the clots. And this is our technique for doing this kind of surgery quickly with no complication. Thank you for attention.